there, and welcome to another episode of Cut to It, the nurse podcast. We cover the OR, but there's also other things that we're going to talk about and smell today. So,
Oh,
our episode today is You Smell It, but Are You Safe? Bone cement vapors. I'm Dr. Rosemary Babo. I'm an OR nurse. I worked in medical affairs, global clinical education, and I am happy to be here with my co host.
hey, Marianne Sanford here, registered nurse, OR nurse, also worked in medical affairs, and I love education. So we're really happy to have you here today, and we'll talk bone cement. So, Rosemary, when I was researching for this episode, there was a clinician, last name was Ryu. I can't believe that bone cement has been in use since 1950.
Mm.
That's a long time, right? So
It's
there's a
a long
lot of
time.
things to talk about, right?
Yeah, hopefully
So,
there's been some improvements.
yeah, and we'll get to that, right? About the consequences and the improvements. So we know that the basic ingredient in bone cement is methyl methacrylate, and as again, it's been around since the 1950s. So there are clinical complications for patients that are well documented:
Mhm.
cardiovascular, their blood pressure, and all kinds of issues that a patient can have when the bone cement is being implanted, right? And we're talking about orthopedic procedures and also some spinal procedures where it might be implemented. There's no known complications through clinical literature with the staff working with the bone cement. There are plenty of things that talk about the consequences that could happen, but
Mhm.
nothing documented specifically that talks about, yes, this was used and this has occurred. There's a limited research even in that it's occurring. So, and of course, orthopedic surgeons are the most involved and affected by methyl methacrylate or bone cement. We were just talking before, you and I, about masks, right?
Yeah.
So, why don't you mention the mask topic? I think it's interesting.
Well, in the orthopedic procedures, generally you'll have a hood on. It's a sterile environment, so you're masked up. We have your hood, you would think all the protective gear that you need to have on. And yet we're still having issues. Granted, it's not profound and like you said, not highly researched and showing up in the literature as you found. I think pretty well. You did a good search. I mean, we obviously, if you're bringing up 1950, you did not even just limit it to the last 5 years, and that's part. And I will say that too. We always do want current literature, but oftentimes people aren't funding studies. People aren't looking at some of these things again and again and again, especially if there's been no changes. So don't hesitate to use a little bit older article if there's just not the topic, and then also you're finding in your searches. And the other thing is maybe you can then improve the literature by doing something in your unit. You've heard me say it before, but it's certainly worth again, because as I kind of just before that, maybe there's been some improvements. Maybe not,
Oh.
but do we know that? So anyway, go ahead. The mask, yes, you would think you would be all PPE'd up in the environment that you are in handling cement.
Yeah, and
Mhm.
I did procedures, total hip procedures, total knee procedures with the hood on. I don't remember specifically smelling the cement, but I do remember as a circulator clearly smelling the cement as it was being
Mm.
mixed and as it was being applied. And, mask wise, say as a circulator or anesthesiologist or whomever, I wonder why you smell it. It must be a molecule that's small enough to get past the masks that we're using, the surgical mask. Perhaps
Mhm.
with an N95, that wouldn't happen. I don't know particularly ORs that mandate an N95. It might be personal preference. I would
Mm.
love to know the answer to that. Again, there's no studies on that. There's plenty
Right.
of studies about the sequelae of using bone cement, but nothing about personal protection. I mean, I looked long and hard. I didn't see anything about personal protection being a mitigating factor for bone cement, which is very interesting. And I agree with you, by the way, about the clinical publications. The absence of clinical publications that are new doesn't mean it's not being thought about. It just means it's not being published for whatever reason. And a lot of the publications that we look at for any of the topics we talk about, a lot of them are older. We try to exclude them, but the absence of publication doesn't mean it's not happening. It just means nobody's looking at it. So that's a great point you brought up.
Well, thank you. And I
Yeah,
found that
sure.
just by the way, I found that with cell phone use and how all these people have, people meaning hospitals and facilities, not able, do not use your cell phone. Like it's, the whole place is going to explode if you use your cell phone. And the literature is very scant. And the reason that they had that with the cell phone use is because it would interfere with the medical devices at that time. Had nothing to do with what our new phones were like. And so I actually contributed to the literature by showing that what all these signs need to come down. It's completely outdated. And that's the way, not only in, I would say recovery once you wake up, but it's such a mode of communication and helping patients relieve their anxiety by the ability to get in touch with people. And then the physicians and surgeons are walking around and they're showing you, what they found during your operation, and they want you to see this. So why can they walk around and yet, the family members can't even have their cell phones? So anyway, that's a little thing that speaks to it wasn't in the literature, but it certainly needed to be updated, and we did. We updated that.
In neurosurgery, that was a long topic of discussion, that when people were putting a cell phone to their ear, was that cell phone emitting some sort of signal or receiving some sort of signal that would cause more brain tumors to occur. And in anecdotal practice, that never happened. So it's interesting that literature, again, that the studies were done, and we were waiting for that to happen, and it never happened. So very interesting. And just to tie it back to the bone cement, the
Yeah, we can go back
clinic.
to that.
Yeah, we can go off topic. It's interesting. It's okay. It's
Let's
okay.
cement that
So the bone
discussion back. Yeah.
we could talk about anything, but we'll talk about bone cement today. Um, there was some discussion in literature about people coming into direct contact with bone cement. Now,
Mhm,
I don't think there's any. I can't imagine an incidence where that would happen, other than maybe a piece fell off the table and somebody picked it up. And why would you pick it up without glasses? So that was sort of interesting. Like,
mhm.
well, of course, you might have a problem with grabbing methyl methacrylate with your bare hand, but I also don't recall that occurring. So that was also in the literature. I did see it once or twice, which was interesting. However, bone cement is a known respiratory irritant,
Mm,
and that's for the people that are working with it, not necessarily the patient if they have a mask on. But sometimes we do spinals, and then the patient doesn't necessarily and might have a cannula in,
mhm.
or not at all, right? So, being a known respiratory irritant. Again, mentioned in the literature, no formal studies on what actually was happening in the lungs. Now, of course, we use mitigating devices when we're mixing the cement, like a suction container, the mixer itself going to our suction devices. So there are some mitigating things that can
Mhm.
help, but even still, you can still smell it, at least to some degree. And
True.
having it be a respiratory, known respiratory factor, I'm sure all of us can say yes, indeed, we we felt it, and sometimes it was stronger than others.
Yeah, and I think too, from the conferences that I've attended, there are a significant amount of procedures now that are done cementless. So we have that going for us in this specialty. And just a few things about the reason for going cementless. Younger, more active patients are what they're finding. Now, if you have a much older or something with the bone density and structure of that individual, then I hope you're not saying, "Well, my knee was cemented."
It was.
Like, what
I'm
I say,
laughing.
"Oh,
Are you calling me older?
I'm an old lady." Well, I'm just
Yeah.
saying, it didn't specifically say, but I will tell you there were, in my experience, people that were having, joint replacements at 40. So, are you an old lady at 60? I hope not, and I do
You
hope
mentioned
that
my age, thanks a lot.
I'm not saying you just mentioned your age. I just said 60. You could have been 70. I have no idea. Audience, do you
What
wanna
is
guess
happening?
Mary Ann's age?
What is
But
happening right now?
anyway, so that was one of the reasons, and actually it's, one of the conference, the AAHKS one that I attended, and 2 of the doctors, Lombardi and Behrens, they have, done systematic reviews, very good research on the efficiency because sometimes they were looking at whether the cementless indeed held up, and they are finding it performs. I mean, you could say equivalent. It was like up to 93% success, longevity without any issues versus the cemented was at like 91 to 92. So
Mm,
that's pretty significant. And it's a lot, I think, um, of significance for what we're talking about, because if there's other hazards to using the cement, why not go cementless? If you can. And I do know that the lecture that I attended was very well attended. So there were a lot of physicians interested in going cementless, and they wanted to hear from those two experts as to why they do so many cementless surgeries. And waiting till you're older and more fragile. I know they say, oh, you'll know when you need it, but sometimes, it's better just to um, bite the bullet, whether you're scared or have anxiety over it. Just don't overthink it. Go and get it done and improve your quality of life. And, there's other things that come along too with having a surgery when you're in better health versus,
mm,
dealing with so much pain, and you've also offset your balance because you waited too long. So anyway, it's not just the products that are used, it's the health of the individual as well, and whether it's fighting off, cement vapors, from a respiratory standpoint, or having it get into your skin. Hopefully the skin's all covered. But to your point, circulators, maybe not. Maybe not.
yeah, yeah, and, talking about total joint hardware,
Mhm.
in the beginning was cemented, of course, everybody cemented, and then cementless procedures. They perhaps I've never seen literature and didn't look for it actually, uh, perhaps maybe implant driven. Right, because they're just like in spinal procedures, it may be only as good as the hardware they're using if it's successful for the patient. So I love the desire to get away from cement
Mhm.
because remember in the beginning when we started today, we talked about how the patient is most affected by the cement, and I can't tell you how many patients we had whose blood pressure would bottom out. I mean, you would know right away, and then anesthesia is working hard to get that blood pressure back up. So a cementless procedure would of course be amazing for a patient just on that level. But again, I wonder about the different implants when they're doing a press fit, like to understand if there's one that's really have more trouble in staying in position regardless of the patient's age, right?
You're
And
onto something. That is one of the things is the design that
yeah, yeah. I
that
mean, there's
matters.
cruciate ones, there's, cross ones, there's all kinds of the different
Mm.
types, but, and surgeons have a preference based
Yeah.
on what their recidivism, people coming back because
Mhm.
the implant's loose or, not working the way they want it to. So, um, and revision, you're going to use cement. You gotta hold all that hardware in there.
Yeah.
But, yeah, in any case, an implant is it doesn't matter if it's a hernia, right? The mesh has to be good mesh, otherwise it won't stabilize the hernia. So that medical device is really important.
As well. Yeah.
And
Well,
yeah,
that sounds
go ahead.
great, and if you have any, things that you have burning that you would like us to answer or look into, or just send us what you're thinking, we're cut to it, and it's cut to it podcast@gmail.com. I hope you will like, subscribe, and interact with us. We certainly enjoy hearing from you and what the other nursing and specialties are thinking about. So that's it for today.
Yes, thanks so much for joining. We appreciate you.
Bye bye.